Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome back to Beyond This with me, Zaheerah Bham Ismail. October is always a month synonymous with breast cancer awareness. While it's something that we see all over, we see the pink ribbons everywhere, it's something more than just being aware. It's about how do we take the steps going forward to ensure that we are having our early screenings, that we're not missing it, that we're not having an ostrich effect of hiding our head in the sand thinking this can't possibly happen to me. Very often when we look at the statistics, it's actually daunting. We have 1 in 27 women in South Africa who are diagnosed with breast cancer. Breast cancer is actually one of the most prevalent types of cancers that are being diagnosed. And across, I think on UN statistics, we had 2.3 million women that were newly diagnosed in 2020. We often talk about the fact that, are we seeing it more now? Why are we seeing such a high incidence of it? And in my studio with me today, I have Dr. Zeenat Dadabhay and Dr. Lucienne van Schalwyke, both from Life Groenkloof Hospital Breast Cancer Unit team. Welcome to the studio.
Assalamu alaikum. Thanks so much for having us, Zaheerah.
Thank you very much for having us.
It's such a pleasure to have you here. I think I love the fact that you come from a holistic team environment. So the discussions are not going to be one-sided in terms of just one perspective on how it's dealt with. When we're talking about these statistics of 1 in 27, we are talking about things that are happening right here in our country, in South Africa. This is not something that is new. Is it because our lifestyles have changed? Is it because we are doing something differently that's causing a higher incidence of cancer awareness? Or is it the fact that we actually do have access to information, access to screening tools, access to medical teams, access to units like yours that are making people a little bit more aware so that diagnosis is happening earlier?
So I think especially in our community, a large part of it is that people are looking for these things. People have this access that you spoke about. We're wearing the pink ribbons, we're making people aware, and we're encouraging people to look for this earlier. So I think we are finding a lot more because we are looking for it.
So when we're talking about, we often say to women, you need to be having your screenings done, or you need to be able to feel if there's a lump. But by that time, surely we've missed something if we're already feeling a lump, because very often we'll say, if I feel anything, I'll let you know. But these lumps are non-painful lumps that come up. You may not even realize it's there until it's fully formed. How late is that in the process?
So exactly. Very, very important point that you're raising there. So the ideal for us is to diagnose a breast cancer or to pick it up before it's even a lump that you can feel in the breast. So the earlier we pick it up, the more treatment options we have, and the greater the chance that we can treat the cancer successfully. So ideally, we want to pick it up before you can even feel a lump in your breast. So that's why we really would like to advocate for screening mammography. Mm-hmm. So going for your mammogram, even if you can't feel anything abnormal in your breast, because then you'll be able to pick it up before it's formed that lump.
Mm. But when we're talking about the screening mammographies, Zeenat, you mentioned earlier to me about having a 30-year-old and an 80-year-old sitting in the room, both having breast cancer. And for me, that's daunting because I've also got 3 young daughters. And at which age do you know that this is the right age to start screening? This is the right age where they need to be checking. How do we make them more aware? Because very often cancers were always associated with women who were past a menopausal age, who were in a different phase of their lives. We haven't seen it. And now all of a sudden we're telling young girls and young ladies, you got to start screening very early.
So Zaheerah, that's one of the things that struck me, like when we started on this breast cancer journey, is you'd often be there and you'd be like, this woman is my age, or you'd be chatting about her kids and it's your age, and it makes it very real. So in terms of screening from the age of 40, the guidelines say you should have an annual mammogram. And if you're at high risk, talking specifically about genetic risk, so discuss these things with your GP or your radiologist. From the age of 30, you should be screening. Younger than 40, they may be doing breast ultrasounds instead of the traditional mammography, and that's just because of the density of the breast.
And when you're talking about going in for these screenings and that you mentioned now talking to your GP or someone like that, because I think also people are daunted. They don't know who's going to be on the other end. Very often people want a woman to be seen to them. They're afraid of the processes, whereas their connection with the GP is something that has been long-standing, someone that's been in their family for years. How equipped are our GPs to be able to guide these processes for women?
So I think the GPs are in the perfect position because, as you've said, they know you, they know your family history. So I think that's sort of a perfect entry into the healthcare system, and they'll be able to advise you. So they know mammography units that follow good protocols. They know mammography units that, if you would prefer to see a female radiologist, they'll be able to refer you. So I think your GP is actually a perfect entry point if you have any questions.
So it's a good starting point from there.
Absolutely.
And just, sorry, if I can jump in with the screening. Just like we have now multidisciplinary teams and breast units, mammography units, as Lucy mentioned, are also, they know what women are scared of. They know what fears you come in with.
Yes.
They know that you'd probably prefer a female. So a lot of them are very well equipped for these very common hesitations that women have.
So you mentioned now in terms of that fear, and I think that's one of the stigmas associated with why women are very hesitant to go for it, because they almost feel like if I go for it and something comes from it, I'm resigning a death sentence for myself, because many of us may not be aware of what processes are involved. I mean, I chatted to the doctors earlier asking them about that. I thought it was a process that's very negative and that's very emotionally draining that you're part of. But you spoke about it, about seeing the end part and the success part. And Zeenat, you mentioned having the chemo port being taken out and how liberating that is, not just for the team, but for the patient as well. These stigmas and these fears around thinking that this is the end when it comes through. How do you manage that, or how do you deal with it? Because it's not always the case for many women.
So I think, yes, it's an emotionally a very tough process. And yes, the prospect of going for a mammogram and the prospect of finding something abnormal on the mammogram is very daunting. But as he said, most of the units who deal with these patients, we know it's scary. And going for that mammogram is actually the responsible thing to do. So you're being proactive, you're taking care of your health. If your mammogram is completely normal, then you have peace of mind. If we do pick up something on the mammogram, it's not necessarily something dangerous. We might have to do a biopsy to see exactly what we're dealing with. But even if we do diagnose a cancer, you have taken responsibility for your health, and we can guide you through that process. And like Z said, it's such a rewarding process to go through this journey with your patients and to see them come out the other side. It's very rewarding.
Does every patient who's diagnosed with it have to do the full process of the surgeries, the radiation, the chemo? Because I think so many people are confused as to what their diagnosis means for them, because it's not just about, I've been diagnosed with this and now this is what I need to do and then it's done. It's a quality of life discussion as well.
Yeah. So, I mean, just with the mammograms, that's why it's so important, because the earlier we pick these things up, the more treatment options we have to offer you. Once you've missed that boat and it's progressed beyond and beyond, it becomes harder to treat. So the earlier we pick it up, the more options we have available for you. And it's not a cookie cutter thing. It's not for each patient. Each patient's tumor is different. Each patient's risk profile is different. Where we pick up the lump is different. Where it may have spread to or not spread to is different. So that's why we have this big multidisciplinary team, because there is no cookie cutter recipe. Each patient is discussed, each patient is considered on an individual basis, and then the treatment is tailored for that patient.
How important is it, or how much of a role does it play when you mention these things in terms of how specific it is for the individual, but how important does the role of support systems play, patient psychological well-being, a spiritual sense of well-being as well?
Makes a huge difference. I mean, we've had patients stop us in theatre before we start to say they'd like to pray. And that gives so much of calm to the patient, so much of strength. We've met patients' families, their families come in, we keep in contact with them. There's access to a psychologist as part of the team, because it is a very overwhelming thing to hear. To whoever's hearing it.
Absolutely. And,
had.
we spoke about the fears in that of being one of the stigmas attached to it, but so's cost. And that's a reality that many South Africans have to deal with, because as much as we think the medical aids are paying, the truth of it is they're never paying everything in full. We were discussing the fact that the screenings are never being paid for as a yearly prerequisite or mandatory screening amount. So how much of that do you think comes also into play of people saying, I can't actually take the time to look after myself right now because so much more is needed for everyone else around me? And we see women stepping back so many times to put themselves last because someone else needs to be taken care of. Someone else needs this. Someone else needs that in the home. And even at the back of their minds, when they know something isn't right, it kind of gets pushed away.
Yeah, so I think that's quite an important point that you're bringing up. And what's not often discussed is the financial toxicity behind breast cancer treatment. And as you've said, some medical aids only pay for screening mammograms every 2 years, whereas the guidelines recommend that patients should, from the age of 40, if they're at average risk, should be having annual mammograms. And so that can be quite difficult to navigate. What I will say is that patients that are at a high risk, so if you have a family history of breast cancer, for example, or if you've had previous breast biopsies, anything that would increase your risk of developing breast cancer, check with your medical aid, because with some medical aids, you can actually register yourself as a high-risk patient. And in that case, your medical aid will reimburse annual mammograms. And that makes it a little bit easier to follow the guidelines.
And in terms of living in a country like South Africa, we're discussing cost at a private care level, but there's a huge inequality with a lot of people also at public system level across all races, unable to access adequate healthcare in terms of timelines. So I often believe that in terms of services and machines that we have, public healthcare's got amazing stuff. I take Barrow, I worked there and I know it's phenomenal. But if we look at from screening, from diagnosis to when the operations take place, to when chemo takes place, radiation takes place, that timeline, very often patients drop off from that because it's so long, it's so tiring. You don't always get a place, you go there. How is the inequality affected quality of life in terms of diagnosis, in terms of being diagnosed late, in terms of effective treatment?
So unfortunately, this is something that permeates every level of treatment at every stage of healthcare, because if we're looking at early screening, we've talked about mammograms and medical aids. That's something that's not available in the public sector. So you may be picking it up late. Your wait lists for theatre are going to be, as you said, you've worked in. So there are systemic challenges that are very hard to overcome, but there is a healthcare system. There are tertiary hospitals. There are options. So if you don't have the financial means, it doesn't mean you should give up and view it as a death sentence. You need to still go take care of yourself, push ahead, and try and access those systems as best you can. There are multidisciplinary teams in state. There are brilliant surgeons and oncologists, and they're not as easily accessible. And we're not going to sit here and pretend, because we do have really huge challenges, but they are available, and you need to do what you can to access as much as you can in your area.
One of the things you both brought up and you mentioned was the fact that if we have genetic history and we have a predisposition to picking this up, tell me a little bit about, for a woman who are watching, who say that I've got a history of it, I've got family history, I know my grandmother or some woman in my line have had breast cancer before. Can they preemptively do things to prevent this from coming up?
Yes. So, patients who have quite a strong family history of breast cancer and also of some other cancers. So it's not just strictly breast cancer, but some of the other cancers as well, such as ovarian cancer. For these women, we can often offer genetic testing. So that's a blood test usually that we can do to identify any genetic abnormalities that would put you at a higher risk of developing breast cancer. And if that test does come back positive, there are preventative things that we can do in terms of, increasing your screening. So some women will say, look, I know I have the information now. I know that I'm at a higher risk. So let's be more vigilant and let's screen me more often. So then we can do that. There's also certain risk-reducing medication that we can look at. And there's also preventative surgery that can be done. This is only really something that we would offer in that high-risk situation. So this is not something, preventative surgery is not something we would offer in an average risk patient. But for a high-risk patient, it can definitely be worthwhile.
So someone coming into your center, into your unit, what would be the first point of call, or rather, who would be the first point of call? You mentioned an entire team that's available. For me, that's also comforting because it knows you kind of have the thing that it's not just reliant on one person, that if one person's unavailable, there will be other team members who are available for you, because this is psychologically and emotionally a very, very difficult journey to walk. And that's why I asked about the support from family members, because if you don't have anyone and you're walking this journey alone, that in itself for me is just such a daunting journey to be part of on its own. And this in itself is emotionally heavy. So how does it work? If someone walks in, who are the points of call? Who are the people that are involved in the process?
So I think generally a good place to start. So as we've said, your GP is also always a good place to start, because they know the units. So that's a good place to start. Radiology is also a good place to start. So often generally you don't need a referral letter to go for a mammogram. Most radiology units will perform your mammogram plus your ultrasound without a referral letter. So radiology, I think, is also a good place to access, so they can do the mammogram, do the ultrasound, see exactly what we're dealing with. If there's anything abnormal in the breast that they need to biopsy, they'll go ahead and do that. And then they can guide you towards the next step, whether that be seeing an oncologist or seeing a breast surgeon. As he's mentioned, we have our multidisciplinary meetings. So every new patient that is seen by either the radiologist, the oncologist, the surgeon should be discussed at that multidisciplinary meeting. Because breast cancer treatment is so complex that no single specialist can handle the whole extent. So the team is key. And we sit together and we discuss all of our patients to make sure that we're giving them optimal care. And also importantly, that we're not wasting your time or your money. So we want to get you to the appropriate specialist as quickly as we can. And we also want to make sure that we're not duplicating things.
Yeah.
So that I'm not requesting tests that are not really necessary. So that we're not wasting your time and your money, and we can get your treatment process going as soon as possible.
I think that's so important for me, because sometimes if it's separated and individual, you end up doing unnecessary testing. You're not part of a vision that everyone sees and end together. You're wasting a lot of time, and that also drains you in a number of ways as well. So I'm so glad to hear that it's done in a more holistic manner. When we spoke about quality of life, and two things, I just want a little bit of input, because I know that there are a lot of women who are watching who are going through this at the moment. And what is your advice when, your hair, you're losing your hair, your quality of life during that process, where people say to you, don't go and do the radiation, don't go and do the chemo, it's just going to burn your entire body, you're not going to have a quality of life after the surgery, just leave it and don't touch anything else. How do you manage with that? Because obviously I know that there's place for medication, and there's place for the radiation, and there's place for the chemo. But how do we manage when people say to you, but everyone tells me it's going to burn everything in my body, and I'd rather have a better quality of life at this point?
So again, there's no single answer for every patient, but every patient that's offered a type of treatment, be it radiation, surgery, oncology, it's because this team of specialists think that it would be of benefit for you. So if they're saying chemo, it's not because we want to expose you to side effects. It's because for your tumor, maybe before, maybe after the surgery, we think there will be benefit from this treatment for you. So I think the trust and having these open discussions with patients, because it's a very valid concern. Am I not just better off not getting medicine that's going to make me sick? It's something that's valid for a patient. And so the patient needs to be part of this decision-making process. They're part of these discussions. And once you've explained, to most patients, once you've had that discussion of this is what we're doing, this is the next step, this is why, usually there's that level of trust and that level of mutuality. and independence for the patient, because they should be part of that.
And I think it's also good that you honor their autonomy in terms of making their decisions for what's best, but it's also guided by professionals who can, based on experience, can tell you what's also good for you.
It's not only experience, it's evidence-based guidelines. Most of whatever we're offering you is evidence-based. So it's not just that Lucy's done X amount of surgeries this year, and so for you we're going to do that. It's because there's evidence that what we can offer you is of benefit.
And again, every patient is seen on an individual basis, and all of this is then taken into account on an individual basis with your team.
Absolutely. So not everybody will require chemotherapy. Not everybody benefits from it. And if you won't benefit from it, we won't give you chemotherapy because we don't, as Steve said, we don't want to expose you to the side effects. Not everybody requires radiation. So I think the best thing is to discuss with your team and see what they would recommend for you. And the other thing is we can't predict how each individual patient will respond to treatment. So someone else's experience with chemotherapy and experience with the side effects of chemotherapy, as valid as it may be, is not necessarily going to be your experience. So I think it's important to be flexible in terms of our approach, and we do listen to your preferences. And if we have to adapt the plan slightly, we will do that. But yeah, individualize. That's the most important.
And again, the support system comes in because it may be easier for somebody who's now with the family to have the discussion with the family, but at times it also makes it more complicated because there's so many different opinions.
There's
so
a
the
lot
patient,
of noise.
And I mean, in our communities, everybody's going to have an opinion on it, right?
And I think that's what's important for me is because what you mentioned now is because we often hear people saying, don't go and listen to these doctors because they just put everyone through chemo and everyone has to go through this. And I love that you said that actually you don't. If it's not of benefit for you, it's not going to be recommended for you. It's only recommended if it's of benefit. And like you rightfully said, there's a lot of noise and sometimes we forget to listen to our own gut or what works for us and choosing our own thing because so many voices are being heard. But which lends into, and I know we're running short on time, this is a complete hazard, but I want to ask you, we live in a country also where there's a lot of cultural influences. A lot of our communities, including the Indian Muslim community, is very reliant on other forms of medication. We're seeing a growing place for people saying they prefer doing a homeopathic, a herbal route rather, not homeopathic, a herbal route instead, or trying alternate medications from their cultures. How do you manage that in your treatment process and protocol? Because living in South Africa, I'm sure you have to make allowances for that. And also, does it actually impact your processes and procedures? Because people often think that, oh, this is not harmful and I can take it anyway and it's not going to make a difference. This is just something I'm doing on the side. And why is that important for them to tell you about it?
So, I mean, there's just so many layers to this question. I'll start quickly. And then, so, like we said, in South Africa, across cultural lines, and in our community, we know this comes up a lot. And we know patients have different things they may want to try, different things they may want to explore. What we can say is what we offer has been discussed and is evidence-based. And anything else that you want to try, you want to do, bring it to your team and talk to us about it. Rather, tell your oncologist, tell your anesthesiologist, say, I'm taking these meds, because we'll be aware of how it may affect other medication we want to give, how it may affect your treatment. So bring that on as part of the treatment plan. Don't do it as something that's totally separate. It doesn't have to be either or. We can respect where you're coming from, but we can discuss what we feel also and what we recommend. And then we need to be aware of what else is in your body, because herbs are not without effects and they may interact with medicine. They may have other side effects. It's a lot easier for us to be on the same page as you and to be prepared, whether it's for the surgery, for the chemo, for whatever treatment you're having.
Yeah, I think it's just important to have sort of open communication with your team and not feel that this is something that you have to hide from them. We'd 100% rather know.
Absolutely.
We'd rather know, and then again, we can adapt our plan accordingly.
And I think that ties in so well to the trust that's being built between the patient and the team, and the importance of having that trust, because at the end of the day, it's about your holistic care. Dr. Zeenat, Dadabhay, Dr. Lucienne van Schalwyke, thank you so much for joining me on air today. I almost feel like I know we've gone over time, but this could be another whole discussion altogether. But the Live Groenkloof Hospital Breast Care Unit is doing such phenomenal work. And the fact that you have people able to access it and access your teams for this makes a huge, huge difference in the atmosphere that we have around breast cancer awareness, and to break a lot of that stigma. So thank you so much for being here.
Thanks so much for having us.
Thank you.
When we talk about breast cancer awareness, it's not just about saying it or being afraid of it. We've discussed with the team here in terms of breaking the stigmas. We talked about the trust that we need to have with our medical team to be able to move forward. The statistics are daunting. It's 1 in 27 South African women that are being diagnosed. And let's not wait until there's a late diagnosis where prognosis is poor or where intervention is a lot more critical. Try and do it earlier on so that we're able to give ourselves a better quality of life. And sit with your doctors. Trust yourself. Trust your gut instincts. Trust the team that you've been put with to be able to make the best decisions for yourself. We have an amana to take care of our bodies, and it's so important that we do that across the board, and we put ourselves in the forefront of it to make sure, because once we're operating on the best part of who we are, we're able to give the best of ourselves. So during this month, it's not just about talking about it. It's not just about posting about it, but it's making sure you take the time out to go and get the screenings done for yourself. Shukran for joining me on this session of Beyond This, because what comes next starts here.